Hello, everyone, and welcome to the PT on Ice Daily Show. My name is Christina Previtt. I am one of Team MMOA, our modern management of the older adult division. We have 3 courses in our geriatric curriculum. We have our 8-week online essential foundations. If you have taken our 8-week course, you can jump in to our advanced concepts course. And then we have our 2-day live course going down this weekend. And we actually have 2 courses for MMOA that are going on this next weekend. Alex is going to be in Greenville, South Carolina, and Dustin is going to be out in California, Santa Rosa. So MMOA is firing on all cylinders, and I guarantee you we're going to be really close to you all very soon. So if you're interested in seeing us live, make sure you check your calendar. Today, I wanted to talk about a concept that we're going to be putting into our advanced concepts curriculum, and that is looking at radical prostatectomy. So I will totally admit, I am an internal pelvic floor physical therapist, but this was a blind spot for me. I was really reflecting at the end of 2022 about where some of my clinical blind spots were and how I was going to fill them. And, I've done a lot of work personally, professionally, advocating for the role of pelvic health in our female population, not only around the perinatal space, but in the older adult space. And I have not done as good of a job at advocating for our male colleagues, our male patients and male clients. And so that is something that I have committed to filling and making sure that I am up to date with the research around radical prostatectomy, because it is a major reason why individuals will be seeking care from a pelvic health therapist, and something that we see very commonly, unfortunately, in our older adults. So let's kind of talk about it. So individuals will go through a radical prostatectomy if they have the evidence of prostate cancer. Aging, reproduction, we're going to show an increase in size of the prostate. That doesn't necessarily mean that there is a malignancy that is cancerous. If you have a growth of your prostate that is not cancer, then that is called benign prostatic hyperplasia. That can lead to some more common complaints of pelvic floor dysfunction, but it is not generally something that we need to treat per se. Rather, we're going to treat the symptoms of that enlargement and what that does to our bowel and bladder function. When it is cancerous, oftentimes the gold standard in the first step, if prostate cancer is determined and you and your doctor decide that this is something that you are going to pursue treatment for. And the reason why I say that is prostate cancer in general, while it's extremely common and it increases in prevalence over the age of 55, it also tends to be very, very, very slow acting. And so sometimes individuals will decide to kind of wait and see before going through any surgical or radiation type of treatment. So when we are going into treatment, radical prostatectomy is generally the gold standard, and it prevents any need for things like radiation therapy if it is done first. When an individual goes through a radical prostatectomy, I have my pelvic model here. So we have our prostate gland here that's kind of, the urethra comes through it. The prostate is underneath the bladder in men. And this gets removed. And then the urethra gets connected back again to the prostate. It is a very commonly done surgery now. Just like any surgery, there's going to be different types of complications like infection, etc. But one of the very, very, very common things that is seen after a radical prostatectomy is incidence of post-prostatectomy urinary incontinence and erectile dysfunction. And that makes sense why we might have this urinary incontinence. And you can see that we're impacting some of the vasculature going to the penis, and that might be causing some issues with erectile dysfunction. But when we remove the prostate, we make our closure for urine and the mechanism around stopping the flow of urine when we do not want to be peeing as relying only on the external anal sphincter. And so we remove some of our control mechanism. So if we don't have the strength in some of our pelvic floor muscles, or our baseline control is a little bit lower, we can have a heightened risk for urinary incontinence post-operatively. And that is why post or pre-surgery continence status is a known risk factor. If you are incontinent or having troubles with continence before surgery, it is likely to be exacerbated post-operatively. So it is important to know that this may be something that individuals are experiencing. And it is something that is going to be on our client's radar, or at least it should be explained, because issues with continence and issues with sexual function can be quite alarming post-operatively. And if individuals were not made aware that this is something that they could be experiencing, it can be quite unsettling. And so let's talk about management of post-prostatectomy urinary incontinence. So when we have individuals with these symptoms, the natural history of this condition is that we are going to see significant improvements over time, with many individuals having resolution of incontinence and sexual function issues within a year. What that means from a medical management perspective is that many physicians are not going to do any other additional intervention until they are at least a year post-operative, so that we can see what the natural resolution of those symptoms may be. Conservative management, including pelvic floor physical therapy, has been highlighted as a potential conservative treatment for trying to treat prostatectomy urinary incontinence in the interim within the first year. So let's talk about why that might be effective by talking a little bit about the male pelvic floor. So we talk a lot about the female pelvic floor. Obviously, our male model, we have one less hole. So we have our urethral opening and our anal opening. We do not have a vaginal canal because babies are coming out of men. Many of my male colleagues say, thank goodness. But we have, just like in the female pelvic floor, we have two layers of muscles. So we have our superficial layer, which includes bulbospongiosis, ischiocavernosus, and the superior transverse perineum that comes across. And then when we are teaching the Kegel, we are working on the deeper muscle of the pelvic floor, and the one that we want to focus on that goes, so we have our external anal sphincter muscle, and then we have our levator ani that kind of wraps around the two sphincters, both the anal sphincter and the urethral sphincter. And when our levator ani is contracted, these hoses are kinked and we are not pooping or peeing when we do not want to be pooping or peeing. And then when we release that pressure by relaxing our levator ani, that is when we are able to defecate or urinate, hopefully under voluntary control. And so when we are looking at individuals who have had a prostatectomy, we can help facilitate that closure of the external urethral sphincter, right? The one that is remained after the prostate is removed, by helping to facilitate closure of that urethral sphincter using the deep muscles of the pelvic floor. And so that is the theoretical construct as to why we would be recommending pelvic floor muscle training post-operatively. When we look at the evidence around pelvic floor muscle training, it's interesting because individuals are seeing that in the short term, individuals are getting return of continent status, or a significant reduction in the amount of incontinence they experience earlier with pelvic floor muscle training than those who do a wait and see. However, our long-term outcomes don't seem to be that statistically different. And that has made sometimes the recommendation that you could do pelvic floor muscle training, but you don't necessarily need to. I don't know about you, but if I was experiencing incontinence, I would rather have that resolved 3 months postoperatively than 12 months postoperatively. So this interpretation that because long-term outcomes are not the same, we do not need to be making this the gold standard, I think is really missing the mark with respect to how can we encourage a a return to health-related quality of life earlier in our individuals who have already gone through such a stressful life event by having a major surgery, having an aspect of their body removed in order to try and prevent a cancer from spreading within their body. And so pelvic floor muscle training, I think, should be advocated for, especially to just learn about what your body does, how your body pees and poops, because as a society, we are so undereducated about our bodies. And we talk about this with our female clients, but oh my goodness, for our males as well. So we see a return earlier to continence status with pelvic floor muscle training compared to just wait and see or weightless controls. However, what we are now starting to see in a recent systematic review just came out last year that was talking about functional pelvic floor muscle exercise. And this is where you're totally going to see our bias between, Jerry and our pelvic health division, where when we compared just teaching the Kegel, pelvic floor muscle training, as compared to pelvic floor muscle exercise that is incorporated into functional movements that focus on strengthening the lower limb and aerobic reconditioning, which one do you think does better? I don't need to give you 3 guesses. We see that functional pelvic floor training is superior to pelvic floor muscle training alone. And in our pelvic division, we have been advocating for this forever. You should not just be in supine teaching a person how to squeeze their pelvic floor on their back, because that is not how we live our lives. That is not how our moms live our lives. That is not how our older males and females live their life. We are trying to encourage movement, and the pelvic floor needs to be integrated into that movement system in order for us to see successful outcomes. And so just focusing on trying to get that pelvic floor muscle contraction very early on, especially with a lot of swelling and those early healing things that are going on after a surgery, absolutely. We may just start by trying to teach the contraction of the pelvic floor for our males. But as we get further post-operatively, we want to make sure that we are incorporating that system into their day-to-day life and what they are trying to do. So ideally, we are teaching pelvic floor muscle training, teaching them how to contract and relax this levator ani muscle, and then incorporating that into functional movements. If that does not work, there are other surgical management options for individuals who are post-operative for a radical prostatectomy that may be thought of or encouraged by a person's urologist. These are going to be things like an artificial urethral sphincter. This is a mechanism that is put into the male pelvic region where they are able to voluntarily activate a sphincter system and allow the bladder to evacuate voluntarily. They're going to have the same urges to go to the bathroom, but in order to open up their urethral sphincters, it's going to have a mechanism that they're going to reach down and tap on. It's going to open the sphincter for 2 minutes and then close it. Or what's becoming more popular, especially if radiation has not been done for surgery, is do a male urethral sling. And so that can be a biological or artificial mesh conduit that's put in that overrides and allows for, that does not require the use of an artificial activation of the urethral sphincter and allows individuals to void kind of the way that they would naturally. So those are other options that will potentially happen if conservative management has failed after a year post-operatively, and something to be considerate of if you're working with individuals who have had this surgery or had some of these considerations. All right, that was a very quick 101 around radical prostatectomy. If you have any other questions, please let me know. I think every Jerry clinician is a pelvic health clinician, and having conversations about what the pelvic floor is, what it does, and what to expect post-operatively can be so empowering for our clients. If you're interested in learning more, this is going to be coming into our advanced concepts curriculum very soon. So take Essential Foundations online so that you can jump into advanced concepts. Otherwise, have a wonderful week, everyone. And I can't wait to talk to you all online. Bye.